Welcome to Health Hour, a session for you by Black doctors, hosted by the Caribbean and African Health Network. Ever sat in a doctor's office thinking, they just don't get it? Or search for health advice online, but you can't understand it? Felt unheard? You're not alone, and you found your solution with Health Hour. Every Saturday at 11 a.m. This is your space where Caribbean and African healthcare professionals speak about health with a focus on Black people. We tackle the topics that keep you up at night: mental health, chronic conditions, preventive care, sexual health, men's health, women's health, heart disease, and much more. All with the cultural context that matters, because our Black doctors understand the unique challenges we face. Here is what you can expect: real talk from doctors who look like you and get it, lived experience testimonies, practical advice, illness prevention and management tips, and a space of understanding without judgment. You also get to ask questions, because your questions drive the conversation. Health Hour, where community meets Black health expertise. Speak about
Good morning, everyone. Welcome to Health Hour. Very pleased to see you all here. Welcome, welcome, welcome. How is everyone doing? We're just giving a few moments for everybody to get logged in and be on the system. Does anyone have any nice plans for this beautiful day? If you just drop in the chat, what plans you've got for later today? Good morning to Charity. And if everyone can also pop in the chat where you are today, what city, what town, where is everyone logging in from today? So I am in London. I'm in London today. And in terms of my plans later today, I don't have any. I'm gonna rest today. Probably sit outside in the garden because I've had a busy week. Okay. Manchester, we've got some folks from Manchester. Welcome from Manchester. So, I'm Natalie Nunes. I am a consultant, obstetrician gynecologist. I work at West Middlesex and Chelsea and Westminster. And I'm hosting today. I have the pleasure of introducing our speaker today. Oh, we've got someone who is going to be building a garden room for their girls, living in the countryside in Cheshire. That sounds lovely. That sounds absolutely lovely. I wish I had those skills. I don't have those skills. I need help with my garden. I just sit in it. That's all I do in it. Fantastic. Somebody's in Salford, sunny Salford. Yeah, it's been a good summer in terms of the weather, isn't it? We've got someone else in London taking mum out for a second time after she's been housebound since last year. I'm so grateful to spend the time with her. That is fantastic. That's really beautiful. Thank you for sharing that. We've got someone in Nigeria. Thank you for logging in. We're so pleased to have you here joining us. That's fantastic. That's fantastic. Really glad. We've got one more minute if anyone else wants to share where they are or what they're doing this weekend, because it's such lovely weather. I've really been enjoying the summer. This is fantastic. Great. Lovely, lovely. Okay. So I'm going to introduce our speaker now. I have the absolute pleasure of introducing someone who works in my trust, and that's so fantastic, which, we've only just discovered each other through this process, which is really fantastic. But this is Dr. Modest Nwanbila. He's a physician and an HIV specialist with extensive experience in HIV medicine, public health, and research across Africa, including Cameroon and South Africa, as well as the United Kingdom. He currently serves as a clinical fellow at Chelsea and Westminster Hospital NHS Foundation Trust, home to one of the largest HIV cohorts in Europe. He combines clinical care with HIV research, including HIV cure trials, antiretroviral therapy studies, and HIV prevention, having also held senior leadership roles within Cameroon's Ministry of Public Health and contributed to PEPFAR-supported programs. Dr. Nwanbila is passionate about reducing stigma, improving equitable access to care, and advancing evidence-based HIV prevention and treatment. So welcome to Dr. Nwanbila. Thank you so much for sharing your excellent knowledge with us today. Just a reminder to everyone, you can pop your questions in the chat. We will collate them and ask them for you. So this is a safe space. Ask anything you want. This is your moment. This is your chance. You've got our ears, you've got his ears, and he's going to answer your questions. So just pop them in the chat for us today. Thank you.
Thanks very much, Natalie, for that very generous introduction. Good morning, good afternoon, good evening to everyone joining in, and thank you for joining in today with us. Permit me share my screen. Just want to confirm that everyone is able to see my screen.
Yes, we can. Thank you very much. Yeah.
Right, sure. I'm Dr. Modest Nwanbila, and as Natalie mentioned, I'm a clinical fellow at Chelsea and Westminster Hospital in London. And over the past 9 years, I've had the privilege to work in sub-Saharan Africa, specifically in Cameroon and South Africa, and also in the UK. And one of the biggest lessons I've learned is that knowledge is power. When people have the right information, they're able to protect themselves, make informed decisions, and challenge misconceptions. Before we begin, I just want to reassure everyone. I think Natalie mentioned this is a safe and judgment-free space. The session is not about blaming anyone or making anyone feel uncomfortable. It's about learning together, having an honest conversation based on facts. And I hope that by the end of today's session, you will leave feeling more informed, more confident, and better equipped to have conversations about HIV within your circle of friends and the wider community. At the end of the session, I'm hoping that we will be able to understand why HIV remains an important public health issue, how HIV is transmitted, and just as importantly, how HIV is not transmitted. To also understand how HIV affects the immune system, the importance of early HIV testing, where to access HIV testing, HIV prevention, HIV treatment, and we'll delve a little bit into the concept of U equals U. So please feel free if you've got any questions as we go along, drop them in the chat box and we'll discuss them during the Q&A sessions at the end of this session. I think it's prefer if I begin by providing a few definitions for some of the terms that we might come across during this discussion. I think understanding them will make our discussions to be easier to follow. And where best can we start by, if not by asking the most important question, what exactly is HIV? HIV stands for human immunodeficiency virus, and it's a virus that infects human beings and specifically targets the immune system, which is that part of our body responsible for fighting infections and keeping us healthy. When HIV is not treated, it gradually weakens this immune system, and over time, it makes it harder for the body to defend itself. Now, let's talk about another term that is often wrongly used interchangeably with HIV, and that's AIDS. You may have heard someone say they went for an AIDS test or they are taking AIDS medications. These are very common expressions, but they are not actually accurate because HIV is not AIDS. HIV is the virus, and AIDS, on the other hand, which stands for acquired immunodeficiency syndrome, is the most advanced stage of HIV infection, which only develops when HIV has been left untreated and the immune system has been severely damaged. You also hear me mention CD4 cells during today's presentation. They are the specialized cells that play a central role in protecting us from infections, and they are specifically targeted by HIV. Another term you hear is ART, which stands for antiretroviral therapy. These are medications used in treating HIV. I'll also talk about HIV viral load, which simply refers to the amount of HIV present in a person's blood. You can think about the viral load as a way of measuring how active the virus is. The higher the viral load, the more virus is circulating in the body. Finally, you hear me talk about viral suppression, which means that the HIV treatment has reduced the amount of the virus in the blood to such a low level that it cannot be detected by standard laboratory tests. I think one of the questions I often hear is, why are we still talking about HIV in 2026? And the simple answer is that HIV hasn't gone away. And when we look at the figures, it's clear why these conversations are still really important. According to UNAIDS, by the end of 2025, there was an estimated 41 million people living with HIV worldwide. So although there's been remarkable progress over the past 4 decades, HIV still remains one of the world's most important public health challenges. In the UK, it's estimated that 104,000 people are living with HIV. And the encouraging news is that the majority of these people know their HIV status and are receiving effective treatment. However, there's an estimated 5,000 people still living in the UK with HIV who do not know they have HIV. And this number is important because someone who doesn't know that they have HIV cannot benefit from treatment and may unknowingly be passing the virus on to others. When we look at the data on new HIV diagnosis and deaths across the UK in 2024, there was a 4% reduction in the number of new diagnoses when compared to 2023, and there was a 14% decrease in the number of deaths. However, what we will notice is that the success at national level does not always mean every community is benefiting equally. And when we look more closely, we can see that there are still some important inequalities. So, for example, among Black African heterosexual men, there was a rather 15% increase in new HIV diagnoses and a 14% increase in number of deaths among Black African heterosexual women. A reminder that our community continues to disproportionately be affected by HIV, and this highlights why community engagement is so important. We need to continue promoting HIV awareness, encouraging regular testing, and challenging stigma. I think one of the areas that causes the most confusion, and unfortunately the source of most of the stigma related to HIV, is understanding how HIV is passed from one person to another, and just as importantly, how it is not. The first thing I would like everyone to remember is that HIV is not spread through everyday social contact. So you cannot get HIV by being around someone living with HIV. Generally, for HIV transmission to occur, 3 things need to happen. The virus must be present in enough amounts in certain body fluids. We're talking about blood, semen, vaginal fluids, rectal fluids, breast milk. And these fluids need a way to get into another person's body. And the type of contact between these 2 people should be one that allows for the virus to enter and cause an infection. When you look at the list on the left, it highlights how HIV can be transmitted. The common route of transmission is through sex without a condom with someone who has HIV with a high viral load, so with high viral numbers. Another route of transmission is through sharing, injecting equipment such as needles and syringes. And HIV can also be transmitted from mother to her baby during pregnancy, childbirth, or breastfeeding. However, this is now very uncommon in the UK because pregnant women are routinely offered HIV testing, and if they're diagnosed, they are started promptly on treatment to reduce the risk of transmission. Another possible route is through exposure of infected blood. Years ago, people could occasionally acquire HIV through blood transfusions, but thanks to the rigorous screening process of donated blood in the UK, this risk is now almost close to zero. Um, Very occasionally, healthcare workers could also have accidents such as major prick injuries, and I mean, like I mentioned, it's a situation that happens very rarely, and when they do occur, they are managed very promptly. Um, Now let's look at the list on the right because this is where many myths still exist. You cannot get HIV from hugging or sharing or shaking hands with someone. You can hug a family member, shake hands with a colleague, sit near to someone living with HIV without any risk at all. You cannot get HIV from casual kissing because saliva hasn't got enough virus to transmit HIV. You cannot get HIV by sharing food or cutlery with someone living with HIV. And similarly, you cannot, spread HIV through toilet seats, gym equipment, or other shared public facilities. These are just common myths which have got no scientific basis. And finally, one of the myths that has existed for decades is that HIV can be spread through mosquito bites. This is simply not true. Mosquitoes do not inject the blood of one person into another, and HIV has not been found to be able to multiply inside mosquitoes or any other insects. What you're looking at here is a graph representing what happens if someone acquires HIV and never receives antiretroviral treatment. And at the end of the slide, I hope you understand why HIV testing is the only way to know your status and why starting treatment early is important. The blue line represents the amount of HIV in the blood, which means the higher the blue line, the more virus is present. And the red line represents the CD4 cells, which, as we discussed earlier, are the immune cells responsible to help the body fight infections. Ideally, we want the red lines to remain high because it means the immune system is healthy. So when someone first acquires HIV, within the first 2 to 6 weeks, the virus multiplies extremely quickly. You can see this on the graph where the blue line rises very sharply. At this stage, some people will develop what feels like flu-like symptoms, so fever, swollen glands, muscle aches, or just generalized tiredness. And others may experience no symptoms at all. And this is important because if someone has got mild symptoms, they often think, I've probably just caught a virus and they will never suspect HIV. And those who have no symptoms at all will simply just continue with their everyday life, completely unaware that they've acquired HIV. Another important point is that people can easily pass on the virus at this stage because there's a very large amount of the virus circulating in blood and other body fluids. Now, something very interesting happens following the first 4 to 6 weeks, where the body's immune system begins to gain some control and the amount of the virus gradually, significantly reduces. Most people feel completely normal, and however, what's happening is the virus quietly multiplies inside the body and slowly damages the immune system over time. People could stay in this phase for up to 10 years or more with very little or no symptoms. And if they don't get tested, they wouldn't know they are living with HIV. As time goes on, however, and HIV remains untreated, the amount of virus gradually increases, and the immune system becomes too weak to protect the body. And at this time, people might start noticing persistent symptoms like persistent fevers, weight loss, and prolonged diarrhea. And if treatment is still not started, the immune system gets overwhelmed and it gets us to a stage that we call AIDS. People become vulnerable to what we call opportunistic infections. So these are infections which will rarely cause serious illnesses in people with healthy immune systems, but they take advantage of weakened immune systems, and without treatment, they can become overwhelming and ultimately life-threatening. Fortunately, this is no longer the usual story in the UK, because today, when someone is diagnosed early, they start treatment and the entire picture changes. The medication rapidly decreases the quantity of the virus in the blood and protects the immune system and prevents this progression to AIDS. And if there's one message I would like everyone to take from this slide, it's that early testing leads to early treatment. Testing is the only way to be able to know you're living with HIV. Early testing leads to early treatment, and early treatment keeps people healthy, prevent AIDS, and stops HIV from being passed on. So, what's the first step in protecting ourselves from HIV? In my opinion, I would say taking an HIV test. HIV testing is the only way to know your HIV status. You cannot tell whether someone has got HIV by looking at them, and certainly you cannot tell whether you've got HIV by, based on how you feel. Another misconception I occasionally come across is when someone says, "My partner has tested negative, so I know I'm negative," or "My partner has tested positive, so I must be positive." Neither of those assumptions are correct. Everyone's HIV test status is individual, and the only way to be able to know your status is by having your own HIV test. And the good news is, in the UK, HIV testing is free, it's confidential, it's quick, and it's easily accessible. Your results remain private between you and the healthcare provider. Um, just looking a little bit at the data, I mean, from the last UK Health Security Agency data, there's been great progress in terms of HIV testing in England over the last year. However, when we look again beneath the beyond the national figures, we see that testing uptake is still lower than expected in some communities, including Black, African, and heterosexual communities, particularly amongst women. If you look at the graph on the right, we can see that Black, African, heterosexual women had one of the highest proportions declining HIV testing, with around 1 in 5 choosing not to take the test. This tells us that there's still persistent barriers to HIV testing, which could be from maybe stigma, fear, lack of awareness, maybe concerns around confidentiality, or simply people not just recognizing personal risks to HIV acquisition. I think the biggest risk for declining an HIV test is having a late HIV diagnosis. When someone is diagnosed late, it means that HIV has already had time to significantly weaken their immune system. And the evidence is very clear. People who are diagnosed late are around 10 times more likely to die within the first year of their diagnosis compared to those who are diagnosed early. And this is not because the medication is not working, but because the virus has had considerable time to damage the immune system before treatment was started. Unfortunately, this remains a particular challenge within our community, and the report says that around half of Black African heterosexuals who were newly diagnosed with HIV in 2024 were late diagnosis. I think one of my favorite messages is about HIV testing is there's really no bad outcome for having an HIV test. If you test negative and you're someone who may have ongoing risk for HIV acquisition, then it's an opportunity to discuss prevention strategies. And if you do test positive, although that can understandably be overwhelming, you'll be referred promptly to a specialist clinic, started on effective treatment, and with today's medication, you can expect to live a long, healthy, and productive life. So now let's talk about where you can get HIV tests in the UK. I think one of the biggest barriers I hear from people in our communities, they don't know where to test, or they're worried that people will find out. But let me just reassure you that there are many places where you can get tested depending on what feels more comfortable for you. The first option is usually your local sexual health clinic. These clinics will provide free confidential HIV testing. You don't need to be referred by your GP. The staff are experienced and they see people from all backgrounds every single day. You can also have an HIV test from your GP. They could organize this for you. For women who are pregnant, it's routinely offered through antenatal clinics. Hospital emergency departments also now routinely offer HIV test on what we call an opt-out basis. So you're offered an HIV test, and it's for you to make a decision whether you want to have it or not. And this normalizes HIV testing and helps in diagnosing people earlier. I think that also community testing programs, often run by charities and community organizations, and this is particularly important because it brings testing into places where people already feel comfortable, such as community centers, churches, and other outreach, like universities. And this helps to reduce stigma and make testing more accessible. And finally, if you'd rather have a test at the comfort of your home, you could use an HIV self-test or a self-sampling kit, which can be ordered online in many parts of the UK. Some of the test strips will be able to give you your results within minutes at home, or you would have to mail a sample of blood to a laboratory and receive your results securely afterwards. So, I mean, I just want everyone to remember you have options, whether it's through your GP, a sexual health clinic, or just the privacy of your home. You can always have an HIV test when you want to have it. And by getting tested, you're taking control of your health. So after taking control of your health, I think the next step is for those who test negative, how do you stay negative? There are now several highly effective preventive options available in NHS. I think most of us are already familiar with condoms. When they are used correctly and consistently, remain very effective. Also have the added advantage of preventing against STDs and unintended pregnancy. We've also got PrEP, which stands for pre-exposure prophylaxis. It's a medication taken by people who do not have HIV, but who may be at increased risk of acquiring HIV. In the UK, there are two forms, the tablet and the injectable form. And there's PEP, which stands for post-exposure prophylaxis, which is an emergency treatment given to someone after they have been exposed to HIV. So as mentioned, PrEP stands for pre-exposure prophylaxis. Think about it as putting on your seatbelt before you start driving. You don't wait until you have an accident to put on your seatbelt. You wear it beforehand. So the PrEP works in a similar way. Its role is to protect you before you are exposed to HIV. And here in the UK, it's available in sexual health clinics, free of charge for people who are eligible. Talking about eligible, you need to be HIV negative and at increased risk of acquiring HIV through sexual exposure. So maybe through having multiple sexual partners, having condomless sex with someone whose HIV status is unknown, or someone living with HIV and not on treatment. In the UK, on the NHS, there are two PrEP options. The first is the oral PrEP, which is a tablet taken off by most people every day, and for others, it could be taken on what we call on demand, where people will take tablets around the time of sex rather than every day. but not everyone is suitable for on-demand PrEP. Usually we will assess whether it's the right option, and if appropriate, explain exactly how and when to take it for the best results. The second option of PrEP is the long-acting injectables and involves receiving an injection every 2 months at the sexual health clinic. Some people will prefer this because they don't have to remember to take tablets, but currently it's only recommended for persons who cannot take the oral PrEP for different reasons, such as medical reasons or social circumstances. People who cannot swallow pills, or people in a relationship where they are afraid of maybe their partner finding out that they are taking PrEP. But both options are very effective, and usually the best option is simply the one that fits your lifestyle and that you and your healthcare professional decide that it's most appropriate. Just to let you know that the process of requesting and getting PrEP is actually very straightforward. You just need to go to a sexual health clinic. You're going to be assessed. You have an HIV test, which in the UK we use an antibody antigen test, which would usually give you an accurate result 4 weeks after potential HIV exposure, and takes about 15 minutes for you to get your result. Other tests will be requested just to make sure that you're starting PrEP safely. I think it's also important to highlight that PrEP does not protect against STDs or pregnancy. So condoms still have a very important role in protecting your overall health. Now that we've looked at PrEP, I think let's move on to another medication that often gets confused with it, and that's PEP. PEP stands for post-exposure prophylaxis, and it's an emergency treatment given to someone negative for HIV after they have been exposed to HIV, to protect them from getting the virus. It's a combination of antiretroviral medications, usually taken daily for 28 days, and usually the advice is for it to be started within 72 hours after exposure. However, the sooner it's started, the better. So we usually recommend that people seek support within 24 hours of exposure. It's also available through your local sexual health clinics, and if you do need, post-exposure prophylaxis outside clinic hours, most A&Es are able to access and provide PEP. And just like PrEP, it's free of charge. It's given to people after an assessment, and if they're found to need it. So if you think you've been exposed to HIV, don't panic, but also don't delay seeking help. One of the biggest changes in HIV over the last 30 years is that a diagnosis today is completely different from what it was in the past. Many people used to hear the words HIV positive, and immediately they think of the frightening stories that they heard growing up. And sadly, those memories still feel very real for many people in our community. However, the reality today is that, if someone is diagnosed with HIV, starts treatment early, stays engaged with care, they can expect to live a long, healthy, and active life. And this slide basically just shows what that journey looks like in the UK, starting with an HIV test and receiving an HIV diagnosis, and being referred to a specialist HIV clinic, which is not only made up of doctors but also professionals whose jobs are to provide support or signpost individuals to places where they can get support. And then, getting a full comprehensive assessment and starting antiretroviral therapy, which could be 1 or 2 pills a day, with the pills usually containing 2 or 3 medications combined in a single tablet. In some people, injectable medications could be considered. However, as per the guidelines, people would only be considered for injectables when they have been stable on oral medications and the viral load has gone down to certain undetectable levels. It's also very important to highlight that HIV treatment and care is provided free of charge through the NHS, regardless of your immigration status. It's also very important to highlight that currently there is no cure for HIV yet. However, modern HIV medications are very effective in reducing the levels of the virus and ensuring that people living with HIV can live a healthy life. Also, when treatment is started, the journey doesn't just end there. The routine follow-up visits and these visits give an opportunity to check that everything is going on well and to answer questions that people living with HIV may have over time. I think this slide is a very important slide. It brings us to a very important benefit of being undetectable, one that has transformed HIV care around the world. And the fact that being undetectable means that there's a zero chance of transmitting the virus. Many of you would have heard the concept called U equals U, or undetectable equals untransmittable. It's not a slogan, it's a concept backed by years of high quality research. And what it actually means, the first U stands for undetectable, which means a person living with HIV, they've taken the medications and the amount of HIV virus in the blood has gone to very low levels. And the second U stands for untransmittable, which means that the level of the virus in the blood is been reduced to such a way that HIV cannot be passed on to the sexual partners. So in summary, when someone is undetectable, they cannot pass on HIV to their sexual partner or partners. Technically, we talk about U equals U when someone has been stable on HIV medication and undetectable for at least 6 months and continues to take their medication. It's really important to emphasize that they need to continue to take their medication. And U equals U is true for everyone, irrespective of sexual orientation and for all types of sex. I think it's also important to discuss what U equals U does not mean. Being undetectable does not mean the person has been cured of HIV. It only means that the medication is effective and keeping the virus under control. It doesn't also mean that when someone is undetectable, they can stop taking the medications. And while U equals U prevents HIV, passing on HIV onto sexual partners, it doesn't protect against other sexually transmitted infections. Before we finish today's session, I think I'd like to spend a few minutes just talking about something that doesn't involve tablets or injections or blood tests, but has got a huge impact on the lives of people living with HIV, and that's the language we use. So sometimes we don't realize that a single word can either make someone feel respected or accepted and make them feel judged or ashamed. HIV stigma is still one of the biggest barriers to ending new HIV infections, and could explain why people often delay getting tested or even starting treatment, or maybe even sharing their HIV status because they're just afraid of how others may react. So, although we've made incredible progress medically, we still have a lot of work to do socially to combat HIV stigma, and every one of us has got a role to play. In 2021, something called the People First Charter was launched, and it encouraged organizations around the world to use a person first language whenever we talk about HIV. And the idea is simple: people should never be defined by a medical condition. They should always first be recognized as a human being with dignity, value, and worth. Let's look at a few examples of the recommendation from the People First Charter on the slide. So instead of saying, an HIV patient or an HIV infected person, it's advisable to say a person living with HIV. Now you might be wondering, does this really make a difference? And the simple answer is yes, it does. When we say person living with HIV, we're putting the person first, and HIV is just something they live with and not who they are. They are actually, someone's mother, someone's wife, someone's father, someone's colleague, someone's neighbor, and HIV is, just only a small part of this person's life. You also notice phrases like, disclose your HIV status. Nowadays, we tend to say, share or discuss your HIV status, because the word disclose can sound as though someone is revealing a secret or confessing something wrong, when in reality, living in HIV isn't something to be ashamed of. And if someone, chooses to tell another person about their HIV status, they're actually sharing something personal, and their choices need to be respected. Um, the same applies to words like infect or spread, words that could sometimes sound frightening or even attributing blame. Instead, we often use phrases like transmit or pass on, as these are more accurate and much less judgmental. Sometimes we think ending stigma requires a big campaign, but often it starts with the words we use when we're talking. And if our language is respectful, compassionate, informed, we create communities where people feel safe to get tested, safe to seek treatment, and ultimately that's how we move closer to ending HIV-related stigma. So I'd like to leave you with one final assignment, which is every conversation you have about HIV should be an opportunity to reinforce positive language and reduce stigma. As we come to the end of this session, I would like to leave you with some trusted places where you can find accurate information, support, and care. Thank you for listening in.
Wow, amazing. Thank you very much. That was such an informative session. Thank you. And those, people first charter is excellent. When you think about it, I think that belongs in all of medicine and not just in HIV care. And that's something that we will continue to promote. And before we jump into the questions, I would like to invite Stephanie Toriyima. She's going to be telling us about the HIV community outreach safe steps. So if Stephanie can share her slides.
Can you all see my slides?
Yes, we can. Thank you.
Oh, thank you, Dr. Natalie. So we have a project in London, Southeast London, called Safe Steps, which is led by Caribbean and African Health Network in partnership with NAS, EMO, and Turning Point. And what we do is we don't just test, we create a safe space, a trusted conversation for a healthier future. So taking care of sexual health should be very comfortable and accessible, just as Dr. Modest spoke about it. So for Safe Steps, is a sexual health project that is surrounded by silence, but because of the prevention work we do, we try to reduce the stigma that Dr. Modest spoke about, fear of judgment, lack of cultural appropriate information, difficulty navigating such services. Because for many people in African and Caribbean communities, it's knowing where to go to, who to trust, and whether they can be judged or they will see someone who might recognize them. So Safe Step exists just to change that. So meeting people in familiar community spaces where they feel confident and supported. So it's actually a trusted doorway, not just a clinic, because a lot of people are scared of going into a sexual health clinic to have a test simply because of the fear of meeting someone who might recognize them. And that's why Safe Steps bring it closer to you, and it's a cultural sensitive sexual health support directly into the heart of the communities. So it's also free, is inclusive, culturally competent, and Safe Steps is a service designed with our community, not just for the community. And will be commissioned by the Sexual Health Alliance, which is Lambert Saddock and Lewisham. So our service is every route to support. So we do things around testing, we'll do point of care HIV screening, we give access to STI free test kits, and we also do like an add-on for people with blood pressure, because we know that people rarely arrive with just one condition. Sometimes the conversation leads to another, and we've noticed a lot of conversation leads into our community having multiple other health conditions like heart conditions and blood sugar, diabetes, and the rest. And we also offer things like condoms and lubricants, and we also do things around condom demonstration, in the hubs. We also offer support services such as one-on-one drop-in sessions. We do clinic chaperoning, where we have a fast-track referral with guys and St. Thomas's. We do peer support sessions. We also refer to other services such as, food bank counseling and other services within the community. We also do education. We have our champions here in the house who also support most of the work we do. And we also do a lot of social media engagement. And then our testing is in a non-judgmental space. Like I said earlier, it's we give you the confidence, we give you the support. We are not judgmental. It's very culturally sensitive. We know the issues around having that cultural sensitivity around testing. So whatever the result is, no one is left to navigate what comes next. So we give you that support from the beginning to let you know what the outcome would be. We're always there to support you. So our prevention is about choices. So there is no single one way to protect sexual health, but we never make it one size fits all. So we tailor the conversation around what matters to you most. So we talk about the different size of condom, because one of the things we've noticed is a lot of people don't know their right size of condom. So we educate you around the right size of condom and how to wear it correctly, both the male and female condom, which the female condom is something that is not very popular. And we do all of that in terms of demonstration and also showing women it's your right to know how to wear condoms. And just as Dr. Modest talked, we show you how to access PrEP. And if you're sexually active, you should know what PrEP is all about. And we have a QR code where you can also, request for your PrEP. We have PrEP online within Lambert, and then we have a PrEP clinic in Lewisham where we can refer you to as well. And we talk about treatment. If someone who is already HIV, how do we support you to remain on treatment? And then we get around communications and consent. What we do around communication is as someone who is sexually active, we make sure you understand what consent is when it comes to your partner. And here is I would like everyone to take a picture of this QR code because it's really important. You have a lot of information around Fine Sexual Health, Southeast London, where you can get all the support you need with all the local clinics and even PrEP and how to access most of the services. So please take a picture of it. You might need it not for yourself, but maybe for your growing children who don't just go on social media and look for sexual health, support, so they can actually use it at their own convenience and also share with colleagues and also family members as well. So I'll pause here for you to take a picture of it before I move forward. Has anyone taken the picture yet? Need thumbs up, thumbs up.
Your presentation was not showing. It's only the last presentation from the doctor.
Right.
No, I've been seeing her presentation. I think there might be like tabs on the top of your YouTube, not YouTube, on the top of your Zoom that will allow you to select to see her slides.
I don't know. Maybe ask others too. I don't know if this happened to me. Maybe some other could not see it. I don't know.
Okay. So can anyone see my slides?
Well, it will be on YouTube after, so the slides will be visible then, so you'd be able to see them. Apologies for that.
Okay, so the support, like I said, we offer chaperoning and advocacy support. We refer to other organizations that are doing the similar, services in the community. Like we don't do everything. When it comes to counseling, we refer you to counseling services or NAS, or we refer you to other counseling self-support that you may need. We do referrals. We also do confidential advice and reassurance. So we have our QR code. We have a dedicated line, which I'll share at the end of this presentation. You can either text us or call us or even WhatsApp us from 8 a.m. to 10 p.m. And because sexual health doesn't exist in isolation for the rest of our life, so anxiety relationship can be a problem. So we are in your neighborhood. So these are the days we are in the neighborhood. In Lambert, you can locate us at Imo office at Unit 9 Warwick House from 10 to 5. And Lewisham, we are there on Tuesday at the Glassmill Leisure Center, Friday at Wardroom Center at Amishan Way, Vale. In Lambert, we're there on Wednesdays at Acumen Health Center, and then on Thursday, we're at Brixton Library. On Friday, we're in Peckham Library as well. So if you take a picture of this, for those who can still see my screen, so you can always come to our hub. You don't need a referral. You just walk into our space, or you can also self-refer as well. So we are just, like I said, you don't have to get a referral to come into our space. You can contact us directly on the number down there. And you can also locate us on social media. You can find us on X, Instagram, or LinkedIn, or you can call us directly or send us an email at team@safesteps.com, or you can ask a professional to refer you to us if you prefer that way, or you can just pop into the spaces like I mentioned. And you can also find most of the information I just presented about Safe Steps on Find Sexual Health Southeast London, the QR code I ask you to screen. So yeah, so Safe Steps, like I said, is in partnership with IMO. It's led by CAN, IMONAS, and Turning Point, and it's a service commissioned by the Sexual Health Alliance in Southeast London. And Safe Steps is here for you, so you can ask all the questions, you can come and screen, you can learn more, and you can get prevented. I know there's a short time for information overload, but if you need more information about Safe Steps, please don't hesitate to get in touch with the number on the screen or come to the spaces that I mentioned earlier, and we'll be able to support you in every way we can. We don't just make one particular service for everyone, but we fit it around you. So sometimes the first step towards better sexual health is not just a test. Sometimes it's simply finding a safe person to speak with. Thank you.
Thank you very much. Thank you very much. We've popped the QR code and some of the dates and locations in the chat for those who may not have been able to see it. And now we've got Ms. Husseina Hamza, who's going to share a little bit on lived experience. Thank you very much, Husseina.
Thank you, Natalie. Thank you, everyone. My name is Husseina Hamza. I'm a co-founder and the CEO of Red Ribbon Living Well. It's an organization supporting people affected by and living with HIV, mental health, and family experience domestic violence. As here, I'm just present as a person living with HIV for 26 years. And what doctor was just trying to explain, so I don't need to go on that, but living with HIV for a person as a migrant myself, I just want to share that. And being in the country, facing a lot of challenge, barrier, especially as a woman, as a Muslim, you look at culture and faith. It was not a smooth journey. It was a long, long journey. But through that, I have managed actually to go through that. And as the organization say, living well, and I'm living well. So what is for people living with HIV, the most, I say living with HIV is a long-term condition, but what is the disease, virus, is a stigma, and is internal stigma or self-stigma. And this is something that we are doing to empower people who are living with HIV to remove that stigma, that they can go out and empower other people. Dr. Modest, have you share all the information that I don't need even to repeat, which is very, very important. I'm touching on the U equals U. As a person living with HIV for 26 years, I am undetectable and I'm transmittable. But sometimes this knowledge is not out there, or there's no trust, because for the work which I'm doing, sometimes when you raise this issue and they say, oh, my doctor have not told me, so I don't trust your community. I have to trust my doctor. As us Black African, we trust more doctor than hear from someone. So what I just want to share that the journey of living with HIV and being actually kind of living well is not easy. It needs a lot of empowerment. It needs a lot of education to empower people. And have shared that most of the newly diagnosed are heterosexual women. This is something that we have seen, but that could be sometimes not being actually diagnosed earlier, because sometimes you can go to health care hospital, they look at you and say, no, you are not, you're not, you can't live with HIV. And it end up actually to be in that way, people to reach at 55 or 65 to be diagnosed with HIV. This is something that as a community organization, we are trying to empower our people. We are trying to work with healthcare professionals actually to reduce this stigma and discrimination for these people to be treated early, detected early. Because as you say, if your person has been detected early, or been transmitted, or been diagnosed early, you can start a treatment. And when you start treatment, the way you've been prescribed by your consultant for 3 months to 6 months, you are undetectable and untransmittable. It's a powerful knowledge actually to give to the community. And the other thing which I'm still saying is about stigma. Stigma is a killer, because what we say, people living with HIV is a long-term condition. The virus, again, I'm keeping repeating, is a stigma. But how can we remove this stigma? Through society, through healthcare professional, through family. What we find that the people themselves who are living with HIV, okay, they mean there are kind of negativity. They feel themselves about blame, okay, shame, fear of even trying to share with someone else. And this causes a lot of anxiety, mental health, because one condition, it causes another condition, you know, and that is something that we need to look at it. And what kind we are doing is a good work, which is working in a partnership to explore and empower our people in the community.
Thank you so much, Husseina. That was really, thank you so much for, opening yourself to share that journey and advice for all of us here on the meeting. We're gonna jump into questions now. So, Dr. Modest, you could probably stop sharing screen, and then I'm just gonna just read out some of the questions that folks have asked of you. So the first question is, can HIV detection be within days of infection, and how accurate would that testing be?
All right. So can HIV detection be within days, and how accurate would that result be? I think in the UK, what we use for HIV testing is standard is the antigen antibody test, which is the 4th generation HIV test, which is able to detect most HIV infections within 18 to 45 days. So we're looking at, less than 2 months, but more than 2 weeks, of course, after exposure, and usually conclusive around 45 days. We've got other testing options like the very specific HIV viral load testing, which tests specifically for what we call a P24 antigen, which is very specific for the HIV virus. However, it's very expensive and cannot be used routinely on the NHS as an HIV test. So, there's also the rapid finger prick testing, which only tests for antibodies, but that would usually take longer, so 90 days. So, in summary, the test would be able to, we can be able to get after exposure. We're looking at, 2 weeks to 45 days, and we can be sure that any results gotten within that period can be quite accurate.
Okay, thank you. So it depends on which test is being done, and what's available. So the kind of routine testing might take a little bit longer, for that test to become positive. Okay, thank you. At what point is a diagnosis considered late?
So a late diagnosis, as we discussed during the presentation, is a diagnosis when the virus has had considerable time to significantly have a negative impact on the immune system. Usually, we've got parameters that we use, and we're looking at. So for every person who's gets a positive HIV diagnosis or a positive HIV test, we do other investigations, including a CD4. So we're looking at the amount of our CD4 cells within the body. And usually we use parameters to determine late diagnosis. So a CD4 of less than 250. In other places, we talk of CD4 of less than 200, we will consider as a late diagnosis. And the reason why is because when CD4 levels go beyond 200, then the body is really, predisposed to opportunistic infections. Apart from the CD4, when people are diagnosed with those opportunistic infections, some of these infections are, I'm going to start calling medical names, so permit me to. So we've got, certain cancers like Kaposi sarcoma. We've got, people have TB, which affects the lungs, but in people who have got AIDS or late diagnosis, we talk about TB that goes beyond affecting just the lungs. So extrapulmonary TB, TB in the brain, in the bone, abdominal TB, and stuff like that. So those defining conditions, which are also known as AIDS defining conditions, when they are present at the point of diagnosis, we can say this person has got a late HIV diagnosis.
Thank you. Thank you very much. I'm gonna jump to a question. Someone has asked, is there a point when your body cannot replace the CD4 cells that are lost?
I'm not an immunologist,
Okay.
but based from the experience in the HIV, managing people living with HIV, we know that when viral load gets undetectable, when the medication has managed to get the viral load to undetectable levels, the body recovers and the CD4s begin to increase. It's true that we have the rate of the decline in viral load and the recovery of CD4 is not the same. So viral load is going to decline very significantly and steeply, but the CD4 usually takes its time to go up. And we've had patients where viral CD4 has gone up and just stayed stagnant around the 300 levels for many years. And we cannot really understand, but there's studies going on, there's lots of research going on to find out why exactly these people have not had a progressive increase in their CD4. So I'm sorry, I cannot answer specifically that question.
No, that's great. That's great. That makes sense. Once you get the viral load down, then the body has that chance to rebound and start increasing those CD4 cells. I'm going to jump in with my own question because I'm an obstetrician gynecologist. I'm all for the woman and the pregnancies and their babies. And you have said undetectable means untransmissible. And I want to ask about that in terms of vertical transmission, as well as not just during the pregnancy, but breastfeeding. And how do women make that decision? How do you counsel them about whether it's appropriate? What is their risk of breastfeeding or their risk of transmission during pregnancy?
Oh, that's a very interesting question, and it's one that has there's a lot of debates around the concept of U equals U pertaining to mother to child transmission, vertical transmission, and it's in several parts of the world it's being approached differently. But in the UK, I think we're taking a more cautious approach, and I think the majority of HIV clinicians in the UK are for the fact that a lot of the research around U equals U was focused on sexual transmission. So basically, undetectable equals untransmittable to sexual partners, and there is the data is not quite clear around transmission from mother to child. So as per the BEVA guidelines, we still think there's a risk for transmission to the baby, even if the mother is undetectable because, we don't have adequate data for that. So the position of BEVA is, having a discussion with the mothers and explaining to them that you are undetectable, you are very reduced, the risk of transmission is still very minimal, but we've not got adequate data to show that it's zero. So it's to give them that information and get them to, make an informed decision on whether they're going to do exclusive breastfeeding, which is what is recommended for those who want to breastfeed, or they will do, exclusive formula feed. But yeah, we wouldn't usually 100% say, U equals U for, mothers and children. Yeah.
Thank you very much. I think
Husseina wanted to say something.
Yes.
Yes, I just want to support Dr. Actually, yes, for mother and pregnant, because before now here, when you are pregnant, is compulsory actually to have HIV test. So from the beginning, the mother is being looked after by the healthcare professional and the community voluntary organization, which I'm a part of, Peer Mentor Mother, for MNET. I don't know if you know that organization, which work with young mother during pregnant. And then, as Dr. Modest say, is about that breastfeeding, which sometimes can be a very challenge for women actually to trust, and that is taking actually the point of the woman, how that service and how being supported, how being the knowledge and educated these women, which is make the women actually to make a choice, because it is a choice. Information is there, support is there from the clinician to the community voluntary organization. So is it a good now? And for me, for the experience and what the work we are doing, we have seen those mothers actually who are breastfeeding, who are HIV positive and breastfeeding their children. Yeah.
Okay, thank you.
But that is individual choices.
Individual, of course. Yeah. So we share the evidence, we counsel the woman, and then, everybody ultimately makes their decision. So I'm going to go one more question because I'm not sure how much time we have because we are over time. Someone has asked, what can be done to educate the under 30s about HIV? Because they recently heard a dental receptionist ask a patient, do you have AIDS? When they actually meant, do you have HIV? What are we doing? I mean, I think we've also already kind of shared a lot of what, the sure steps and the education, but in terms of education of the younger people, how are we approaching that?
Well, I think educating the younger people is more about identifying strategies on how to reach them. I think a lot of the younger people now are so into social media, and it's coming up with and working alongside, because much of the work we do is as clinicians we are a lot of focus on the medical aspect, and we just want to routinely care for people living with HIV. But the community, community engagement and the community organizations out there are doing a lot of, that the bulk of the work in, HIV awareness and coming up with strategies to bring the knowledge, adequate knowledge out there. So through community outreach programs, reaching out through social media channels, just to share educative, talks on HIV and dispel misconceptions and myths. I think other strategies which I've seen working in other places is like using community champions, social media, how the influencers and churches, especially in our community, the Afro-Caribbean community. I think we can work alongside church leaders who serve like gatekeepers, and even barbershops are a big place where we can put posters and just People come to do their hair. They've got posters. I mean,
Yeah.
I'm not sure how many young people are reading nowadays, but yeah, it's all about just targeting, those avenues where
Yeah.
they reach a lot of young people. It's all about educating, sending out the right information, and
Yeah.
dispelling
Yeah.
misconception.
Great. I've just got one other quick question I'm going to read here because this is quite heartbreaking. So someone, and I'm so sorry that you had this experience, but they had some sexual violence and they wanted to go on PEP. And they went to A&E and they said this was quite many years ago. But they were only given, I think, a week's worth or 5 days worth, and they said they needed to report to the police to get the rest. Is that still the case? How does someone who's been a victim of sexual violence access PEP?
Wow.
Yeah.
To whoever dropped that in the question and answer box, just want to thank you for sharing your experience, and sorry that you had to experience both sexual violence and what seems to be like, a barrier to accessing treatment that you obviously needed. I think based on the BEVA guidelines, there is no requirement for a report, of sexual assault to the police prior to starting PEP. Your eligibility for PEP depends on, your assessment with the medical team, and an HIV test that comes back negative, and other investigations that rule you not to be, have any contraindications to taking what we currently give as PEP. I know usually what happens is A&E department, because many at times the people who work there have not got, the competence in managing particularly HIV. They usually give a starter pack, which is usually 3 to 5 days, and they advise you. So if it's a weekend, maybe Saturday or Sunday, they give you 3 to 5 days and advise you to go to a local sexual health clinic for a comprehensive assessment on another working day, which will be the Monday. So we call that a starter pack. A starter pack literally is PEP. It's just a shorter course. And when you do get your assessment on the next working clinic day, and then you get a full assessment, if there's any contraindications, for example, to what we're currently giving as PEP, then your PEP options might now be changed to another PEP option. But ultimately, you have to be on, a 28 days course of PEP. So I'm not sure what, I think even in 2019, I mean, if 2019 I was still working in Cameroon, and if Cameroon still, was able to offer PEP to people without needing you to report to police, then I think in the UK, many years ago, that would have also been the case. So I'm really sorry that you had this experience, and just to make it clear, there is no requirement. We don't need a police report. I mean, as long as you come to hospital with, you've experienced sexual assault, you're going to be assessed and you'll be eligible to start PEP. And, that's the medical aspect. The other social aspects and the police report are other aspects that have to be dealt with. But it doesn't kind of make you not eligible for PEP. So, yeah, that's quite unfair. That's quite unfair.
Thank you very much. I think Hussein has one last word, and then I think I'm going to hand over.
No, I was just supporting about the young people. First, the young people, and then the second is young people. Most of the young people now, what we found out, they're more on the media, internet searching. And then to engage with these young people is to find where they are. It's very hard, which is something that we have been even trying to do that, but it's very, very hard to get these young people. One thing about the young people who've just been asked by a healthcare professional, this is something which we are raising this awareness, and we are advocate, especially for healthcare professional, actually, how to speak to people, how to engage with people. And we just launched, I think 2-3 weeks about the it's called voice like mine chatter is about actually understanding the healthcare professional to understand how they can engage, okay, how they can talk to people who are living with HIV. The second thing, again, is about the, sorry to hear about the experience which the person who have been experienced. And this is what we talk about healthcare professional. I'm sure the healthcare professional are here too. How actually they look at it, because sometimes we found that it's kind of ignorance, or look at a person and say, no, we can't treat you, or we can't give you this information, because this person, as you say, is there. PEEP is for there to support these people, especially of that one who have been sexual abused, is important, and actually to act quickly. Yeah, so maybe it's just to look at the healthcare professional, but now things are starting to move well because of us, voluntary community organization, all the work we are doing. Hopeful that these things is not going to happen again. But even if it is happen again, it's good to know where it is, and if the person can share which hospital, because we are working all London, pan-London, everyone. There's a lot of organization who do the same work.
Okay, thank you so much. Thank you again to all our speakers. I'm sorry we can't take any more questions, but please contact Khan or Sure Steps, all the resources that we put out there for you. I'm going to hand over to Wisdom now. We're going to need to close, but thank you very much to our speakers, and thank you very much to those who attended.
Oh, it's gone. Thank you, everyone.
Thank you, Natalie and Nunes. Thank you so much. Yeah, so before we close the session, I'd like to extend my sincere appreciation to everyone who contributed making this health hour a success. And a special thank you to Dr. Modest for delivering such an informative and engaging presentation on HIV. And also, thank you so much again, Natalie Nunes, for hosting today's session. And so it was so professional and ensuring the discussion flowed smoothly. I also like to thank Husseina for chipping in on a short presentation about HIV and how and the awareness, and Stephanie for safe steps. Yeah, so if you could see my screen, I'll really appreciate. Kindly let me know if you can see my screen. All right,
Yes,
thank you.
screen, thank you.
Oh, okay. Yeah, so same time next week, we'll be here again, and the topic is about fibroids. You have more options than you think, presented by Miss Natalie Nunes herself. It will take place on 1st of August, same time, 11 a.m. to 12 p.m. So if you're interested, kindly register by scanning the QR code or send an email to info@can.org.uk. Happening. A second. Yeah, so our next slide is on the Black History Month. We are excited to announce the Greater Manchester Black History Month civic launch on 24th September. This event officially opens Black History Month, bringing together community members, civic leaders, organizations to celebrate Black history, heritage, and achievement. It promises inspiring performance and the launch for the month program. For any inquiries and questions, please contact bhm@can.org.uk, and also you can register by scanning the QR code. Yeah, and then the next slide is emotional resilience and coping strategies. So this Empower the Voice panel is a space that puts some of us down, like share honestly about being open to build the tools to move on from maybe trauma like surviving to thriving. This is on 13th of August, 4 p.m. 4 p.m. at the Methodist Central Hall, Manchester. And the postcode is M11 1JQ. So this you need to join us to build like real emotional resilience and confidence, like practice self-care coping strategies you can use to reflect and connect and be heard in a safe space and supportive space. So any questions, please email us at dvsa@can.org.uk, and the phone number is on the screen. You can book a ticket to join us on that day. And so the Windrush conversation, this is a free confidential, like one-to-one support in the Northwest to apply for the Windrush scheme. So the check that we're doing is to check if you are qualified. Yeah, bringing by gathering information, filling forms, telling us a story, and submitting a strong claim. So the next drop session is happening live at Liverpool. Liverpool, that's next week, 30th July, at the Central Library from 10 a.m. to 4 p.m. So any enquiries, kindly send an email to advocacy@can.org.uk to get started. And safe steps, as my colleague shared more light on it today on the presentation. Yeah, it's more about testing. It's more than testing. It's about feeling understood and respected and supported. Safe steps bring free, confidential health services into your community across the boroughs in London. That's Lambeth, Southwark, Lewisham, and Lewisham. So things that happen is testing, condoms, self-testing kits, advice, and more in space where you already feel comfortable. So for more sexual health and contraceptive services in Southeast London, please visit the website findsexualhealth.org.uk. And also you can find local services via Sexual Health, and that's the QR code there for more information. Thank you for joining us today. I hope to see you next week. And I'll hand it over to Natalie. Thank you so much.
The Caribbean and African Health Network. And that's our time for today. Whether you joined us on Zoom, Facebook, LinkedIn, or YouTube, thank you for making the Health Hour part of your Saturday. We hope today's session gave you the right dose of health wisdom that you can share with your friends and family. When we share knowledge, we strengthen our entire community. Mark your calendar. Next Saturday, same time. Got a topic in mind? We want to hear from you at health@can.org.uk. Health Hour, hosted by the Caribbean and African Health Network.